for lack of better terms, they're real weenie. They're just not very good threads. So they're re-engineering these to more of an American immediate load type taste.
Okay.
Once they've got that, I think this is the implant to use.
All dentists know the common career paths, but how do you know which path is right for you, and are there other options out there?
On this podcast, we will be chatting with industry experts. We want to bring you the knowledge and resources you need to take your career to the next level and break down those industry secrets interview by interview.
We are here to ignite a revolution in the dental landscape
and help you, the dentist, build the career you have always wanted.
I'm Dr. Cassidy Reeder.
I'm Carter Frank.
And welcome to the Revolution Dentistry Podcast.
I'm Carter Frank here with Cassidy Reeder. This is the Revolution Dentistry Podcast, where we help you with strategies to build lasting success for yourself and for your family. Today we're welcoming a very special guest, Dr. Chris Winterholler. Dr. Chris Winterholler is a highly experienced dentist who has dedicated over 30 years to perfecting the art of dental implants. With an impressive track record of placing more than 16,000 implants and completing over 2,500 All-on-X arches, Dr. Winterholler is a true pioneer in the field. He received his initial training in the mid-90s at the Malo Clinic in Lisbon, Portugal, where the All-on-4 technique originated. He is also a fellow of the Academy of General Dentistry, a prestigious achievement earned by less than 5% of dentists. Additionally, he holds the title of Diplomat of the International Congress of Oral Implantology, one of only 6 in Arizona. As an entrepreneur, he had success building 3 de novo practices on his own. His current venture, Winterholler Implant and Restorative Dentistry, is debatably the most advanced and comprehensive implant and CAD/CAM restorative dental office in Arizona, with its own full-service, state-of-the-art digital dental laboratory. His service includes proficiency in dozens of implant systems, including zygomatic implants, transnasal, transsinus, and digital subperiosteal implants. Beyond his professional accomplishments, Dr. Winterholler is an active volunteer in his church and various charities. He treasures his role as a dad, grandpa, and pilot. Join us as we delve into his journey, insights, and the passion that drives his work in dentistry. Welcome to the podcast, Dr. Chris. Super excited to have you.
Thank you for having me.
Of course.
It's exciting for me to be here.
Oh, well, thank you so much. We wanted to introduce you to our listeners a little bit. Can you share what initially inspired you to pursue a career in dentistry? And specifically dental implants?
I grew up in a little town in Wyoming that got really cold in the winter, 30, 40 below. So we spent a lot of time indoors and not a lot to do in a small town. So I was big into building model cars and the USS Constitution Revel model kits.
Oh.
Building Star Wars airplanes out of toothpicks and a nail clipper. So I've been proficient dexterity-wise my whole life. I can fix things, but I guess probably the most reason to answer your question was I had an uncle that was a dentist that had a pool table in his basement and was just a great guy. He was a member of the school board. He sang at everybody's funeral. He was a giant. And I thought that's a great life that guy's made for himself, helping people, doing dentistry, doing something fun, and he was able to raise a family. So shout out to the late Scott Meeks Welch of Lovell, Wyoming, DDS, who inspired me to be a dentist. I've also got a brother that's an oral and maxillofacial surgeon. I'm the youngest of 7.
Wow.
So I was kind of inspired by him. I've got a brother-in-law that's still practicing oral and maxillofacial surgeon. My wife's a dentist.
What?
My father-in-law is a dentist. Her uncle is a dentist. 2 of his sons are dentists. Uncle Scott has 3 of his sons that are dentists. There's about 15 of us all throughout the West. So I was either going to be a dentist or a plumber.
They didn't really leave you much choice, now did they?
Well, I was getting into a plumber apprenticeship program, and my letter of acceptance to Creighton came. So here I am talking to you fine people.
My grandfather went to Creighton. He graduated in 1956.
Yep. I remember seeing his picture there.
Really?
Yep. George Blue Spruce.
Yes, the first American Indian dentist. Isn't that crazy?
Yep. I saw him
Wow.
there. So Creighton's a great place.
Absolutely. Absolutely. That's so cool, your story. You know, it's just incredible what you've accomplished so far. You know, it's just simply incredible. You know, you completed your training at the Malo Clinic in Lisbon, Portugal. How did that experience shape your career?
Well, I think there was kind of something, if you go back historically and you look, and you're referring to the Malo Clinic, that's the originator of the All-on-4 for listeners that may not be familiar with that.
Thank you.
So a general dentist with a prosthodontic certificate named Paulo Malo, back in the early 90s, started trying to figure out a way to rehabilitate people without having to restore one implant per every tooth. And he'd stumbled across some ideas using 4 implants placed strategically in the mouth to be able to put a fixed implant bridge on. Portugal had a really severe drug problem in the 90s. And so economically, it was something that was a necessity to take younger people and put them back into teeth as economically and as streamlined as they could. So that's the origin of the Malo Clinic. But around 2006, so I got to correct the dates just a little bit. Around 2006, I'd already been doing implants right out of dental school from 1995, but I wasn't doing them in a fixed implant bridge fashion. We were doing overdentures and singles and 3-unit bridges and stuff with them. But about 2006, you know, the big corporate entity called ClearChoice came to town in Phoenix. And in my operatories where patients sit, we have TVs for people to watch while they're getting their procedure done on the ceiling. So it irritated me in 2006 that I'd sit in there, be doing or restoring an implant, and then that ClearChoice TV commercial would come on the TV, no. And the patient would point to it and they'd say, well, how come you're making me wait 6 to 8 months to have a teeth when you can get it done in a day or two at this ClearChoice thing? And I thought, I'm going to find out what these guys are doing.
Wow.
And that's when I talked to my implant rep at the time and said, what's going on over there? That's just not legitimate, is it? I'd already done some anteriors with immediate loading clear back in 2001, where we were able to place what's called a Nobel replace implant, like in a central or a lateral, and then put a zirconia pre-manufactured, not custom abutment on it right away. And then I'd take my CEREC machine and cut them a Emax or a Vita Mark II crown on top of it the same day. So we'd started doing that in 2001.
Wow.
So immediate loading wasn't a fear for me. It was just, how do you figure out how to get all the implants lined up so that the bridge would connect to them on the same day? And that's where the Malo Clinic came in.
Wow.
So I believe it was 2007. I went and spent 2 weeks with Malo at his clinic there in Lisbon, Portugal. There was, I think, 4 of us from the United States that went over that year, one of which was Mike Gulpa, who's a big name in implant all-on-4 dentistry. And we watched Dr. Malo, ate lunch with him, rode in his car with him, had a great time with the guy. He treated us like, you know, we were long-lost dental school friends. And got to see kind of how he was doing it in volume. And it's quite an impressive place still, even today. I think it's a 13-story or 11-story building, something like that, like a skyscraper. And people fly into the Lisbon airport every morning, and there's, you know, some guy there at the limo line when you go to the baggage claim, and it'll have somebody's name on it. Malo Clinic underneath it. So people are flying in from the Middle East, Eastern Europe, every morning to Lisbon. They get to the clinic, they go through, physical evaluation, and by 10 o'clock they're in surgery, getting their teeth extracted, getting the implants done, and then they sit in a recovery room till later on that afternoon. And the lab starts working on their teeth, and so they get a new set of teeth probably by 4 or 5 o'clock that night.
That's
I remember this
awesome.
This is 2007, so nothing was digital, nothing was as sophisticated as what we're doing now.
Right.
But the crazy thing about doing an all-on-4, or let's call it all-on-X, or W4, G4, everybody's trying to trademark it. 3-on-6, some guys trying to trademark
Oh,
that.
really?
The magic of it is when a dentist does it, or when he sees it, it's like crack cocaine to a dentist's brain. They wanna keep doing that, and that's what happened to me that many years ago. So since then, I've focused my training, my CE regimen, my office. My office is specific built for the full digital integration of the all-on-4 and perfecting the technique for efficiency, for streamline, and giving a predictable result. I feel like we're even far beyond some of the big corporations that, now that they're big, can't adapt. They can't incorporate
Right.
technology as fast as what I can. So if something new
Right.
comes out, I'm usually within the top 5 guys that gets it
That's
worldwide to be
awesome.
able to pull it off.
That's
Anyway.
awesome.
Did that answer your question?
Absolutely. Thank you.
So as implant dentistry becomes more popular, a bunch more systems come out. What systems do you prefer, and what features do you find the most beneficial in your practice?
I could go on for a full podcast about all the different types of implant systems. I think the keys of, contemporary implant dentistry in 2025, you want something with a fairly aggressive thread. So
Okay.
a couple of the implant companies, historically, I'm going to pick on a couple of them, like, say, for example, a Straumann Tissue Level.
Mm-hmm.
The threads aren't that aggressive. Those implants are not necessarily meant for immediate loading
Okay.
because of the thread taper and the thread design, and because they're made with a bullnose tip. So you have to drill very precise depth or extended depth to be able to get those to go.
Okay.
And they don't make multi-unit abutments on them. So the types of implants that I think are ideal for the all-on-4, or even just a broader range, I really like Dr. Jerry Nisnik's invention of what's called the internal hex
Uh-huh.
with the 45-degree lead-in bevel.
Okay.
So examples of that particular type of implant are, the one I use right now is from a company called Norris Medical.
Mm-hmm.
They're from Israel. The Implant Direct Legacy series is all internal hex. There's a company here in Scottsdale called High Tech
Mm-hmm.
that makes an Israeli implant that's really good.
Okay.
Zimmer is an internal hex.
Mm-hmm.
That's a big popular brand of implant. Most of the Israeli implants are internal hex, and that connection, established in the late 80s, is still I've kind of feel the gold standard of what the implant geometries or connections to an abutment should be first and foremost, or if not, your first choice, certainly your second.
Right.
So internal hex. I'm not a fan of the conical connections.
Okay.
I think they're weak. I've seen, I've probably done 4,000 or 5,000 Nobel BioCare active implants with that conical connection.
Mm-hmm.
And they last for 5 or 6 years, and then all of a sudden you see bone loss around them. And the implant sometimes splits because they use
Wow.
a commercially pure titanium. So I like an implant that has an internal hex connection.
Mm-hmm.
I like a fairly aggressive thread for immediate loading.
Uh-huh.
I want a sandblasted, nitric acid washed implant.
Okay.
And I want a broad prosthetic catalog for not only stock, but custom abutments, including pre-milled abutment connection blanks that we can mill in our office for custom abutments.
Mm-hmm.
But most importantly, a multi-unit abutment, which facilitates the all-on-4.
Right.
All-on-4 didn't exist before the multi-unit abutment or the transmucosal multi-unit abutment.
So you're saying it's a pretty simple order. what you require, what you need, you give your patients the best.
Yeah.
So
So
go ahead.
I wouldn't necessarily stick with a brand. I would stick with a connection and a thread profile for the most general use implant. And then as you ask me questions, I'll talk about some of the new ones that are coming out.
Yeah, absolutely.
That make a difference. I also like the SIN. I like Neodent. And then I'm kind of biased towards the TRI right now also.
Oh, man.
It's abutmentless.
We can't wait to get into that.
And I'll tell you, the TRI, well, I'll wait. You guys ask me questions about that.
No, I mean, I was just going to ask, so like, on average, how many arches are you able to place in like a given day, in a given month? What advice would you give to other dentists aiming to reach that level of productivity, efficiency?
I've done up to 8 arches in a day with surgery and
oh my gosh,
conversion.
That's impressive.
You're working pretty hard. Yesterday we did 4, including some zygomas.
Wow.
And some pterygoids. Most of the time I'd say, 2 arches a day. If you could do 2 arches a day the rest of your life and breathe through your nose at the end of it and leave home at 3, make the tuna casserole for the wife when you get home, you're having a pretty good day.
Yeah.
But, just it's systems. You've got to have your systems really set up. Photogrammetry is a must. In-house lab is a must. I could go on for days on a podcast about all the pitfalls and foibles of perfecting the in-house laboratory.
Oh, we'll have to get you on again for that
which
episode.
Which we've been through. And so we make everything on site. We print everything or mill everything. We make all our own zirconia appliances. We make all of our indentures if necessary, all of our crown and bridge. I've got 2 technicians. And then you got to have some surgical skill and some confidence, which there was a big thread on Dental Town this week that some guy had asked, how do you get to the level of being able to crank out, all-on-4s at a Costco coupon rate? That's a lot of work, and it's a lot of infrastructure. We've got a lot of capital equipment behind us and a lot of talented team members that know their place and know their time of be able to execute those eight arch days.
So you're saying that an in-house lab is pretty essential for that kind of productivity.
Yeah. You can't do all-on-4 consistently. Let's say if the perfect all-on-4 practice, you just get a case every day or 3 arches a day. You do a big double arch in the morning, you do a single arch in the afternoon. You still kind of got to deviate into the in-house laboratory, even if it just includes a 3D printer and a remote designer. That's kind of a must to be able to get the flow going. Photogrammetry, in my opinion, is a must also, because if you don't have photogrammetry, which is an expensive proposition, you're having to do verification jigs, plaster jigs. It'll make your time to effectively fabricate an all-on-4 and not have to follow up on it with broken screws or ill-fitting prostheses. If you don't have photogrammetry, you shouldn't even be in this business, I think, is kind of the...
That's powerful.
I've come to that conclusion that in fact, we've got redundant systems in our office for it now, because I don't want a software update or a Windows update crapping out my Micron mapper.
There you go.
If it does, I'm going to jump over to iCam so that we can still execute. That patient's waiting to wake up with teeth. And if you have a technical support issue, that's a bad day.
I mean, something tells me you've experienced some nightmare situations.
We've always found a way to get out of them, whether we go back and convert, which I don't like to do, but there's only about 3 cases in the 2,500, 3,000 of them that we done that we weren't able to load.
That's crazy. 2,500,
So-
3,000 cases. That is insane.
That is insane. So it's obvious that you're very knowledgeable in the implant side, and you've been on this implant side for a while now. What advice would you give to a dentist who is wanting to offer All-on-X implants to their patients in a general dentistry office?
I heard a really interesting comment yesterday, and I'm sure I'll take some heat for this that will answer that question. My nurse anesthetist yesterday, we had an ASA 4 type patient that I explained to her, I go, you might not make it through this surgery, but she really wanted her teeth.
Wow.
And so we called a nurse anesthetist. We got clearance from cardiology, pulmonology, primary care physician. Nurse anesthetist felt comfortable with the case. And we had that stern talk to her afterwards. And it was a quad zygoma case.
Wow.
Revision.
Oh
Another
my
dentist had,
gosh.
another dentist had done her upper arch in 2012. I did her lower arch in about 2014. The upper arch completely failed and took all the bone with it. And so she'd had the taste of All-on-4. She just didn't want to ever have to go into a denture.
Mm-hmm.
And so we went in there and took everything out, got it cleaned up, got all the defects, fixed it up. But to answer the question, what does it take? Ask your question again. I lost my path because I want
No
to be
problem. The
direct.
question was, what would it take for a dentist, just a regular GP dentist, to start adding All-on-X implants to their general dentistry office?
Yeah. So I think you have to understand that when you do consultations with people, there are barriers not only in the dentist's mind, but in the patient's mind to the cost of what a proposition like the All-on-4 is. You have to be able to be confidently diagnosed. I can count on one hand how many partials we've done in the last 10 years because we just don't have that type of patient base coming to us for partials. They come to us and they want implants.
Mm-hmm.
So what does it take a dentist to be able to confidently? You need to be able to go back to the fundamentals of your sophomore year in dental school, which is diagnosis. We know that there's, multiple aspects to a correct diagnosis with dental disease. First and foremost being, do they have decay? We got to address that. Do they have periodontal disease? We got to address that. Do they have occlusal disease? That's the one that's most likely completely overlooked.
Mm-hmm.
Occlusal disease to me is kind of the keystone of being able to recommend an All-on-4 to a patient, because a lot of these patients have already lost all their teeth. These are mysterious cases to a lot of dentists. They don't know where to start. The patient is frustrated with a lifetime of accumulated dentistry to the point to where they're looking for something that's cost efficient, that's time efficient,
Mm-hmm.
and that solves their problem and keeps them from what I call the dental whirlpool. Because we have patients come in that are, experiencing, they've already had a full mouth reconstruction. They've already had a few implants placed in here. But now they're at the point where the root canals are starting to fail. They're getting a picket fence up front. And somebody has to be able to sit down with them and say, okay, we can do this in a conventional fashion, and we can go in there and crown these teeth. But I see here that you got dry mouth syndrome, which is quite prevalent in society now. If you're on more than 3 to 4 prescription medications, you've got dry mouth or xerostomia.
Mm-hmm.
So if we go in there and rebuild all these teeth, we might get 3 to 5 years out of them, and it's going to cost, X times 50.
Mm-hmm.
And we might be having this conversation again in 3 or 4 years, or I'm hopefully 10, but not more than. And like I had a guy flying from Wisconsin yesterday, was one of the cases that had found us on the internet. And he was 38 years old. His teeth were shot. And the poor kid had been on so many courses of antibiotics, and the teeth were, decayed clear down to the furcation and a lot of his molars. They just weren't salvageable.
Right.
He didn't want partials, he didn't want dentures. He came in and wanted implants done. And so to answer your question again, being able to talk to people and to discuss with them kind of the reality that we're all mortals. We're only going to need our teeth for about 100 years. If you're 80, you got 5 years left, but you can't eat. That person, that might be the only thing that gives their quality of life back, is to be able to be social and to be able to eat.
Right.
So it doesn't matter how old you are, how close to the pine box you are. Just like Brandemark said, I believe that people shouldn't die with their teeth in a glass.
Right.
We want to keep them in teeth. So we offer those solutions. So that's your first answer to the question. What can people do? Being able to present advanced treatment confidently, and then being able to go in and execute a surgical plan that is usually determined by a CT scanner. So you're going to need a CT scanner to be able to treatment plan these.
Okay.
You're going to need some basic understanding of the implant geometries and anatomy. You have to understand that All-on-4 or All-on-X requires prosthetic space. So how many of you guys, Cassidy, have you done any cases yet?
I've done some implants. I'm still working on my All-on-X certification.
Okay. So the biggest kind of speed bump that keeps people from properly doing an effective All-on-4 practice is we're taught in dental school that bone is sacred. It's the temple of never touch it, always preserve it.
Right.
The problem with an All-on-4 is the materials require a certain amount of space, which the minimum is about 12 millimeters, the maximum is about 15 millimeters.
Mm-hmm.
So if you go from incisal edge position to the CEJ,
Mm-hmm.
that's about 10.5 millimeters on average.
Mm-hmm.
So if you try to make an All-on-4 that's 10.5 millimeters thick, it's going to drive you crazy. You're probably going to get a board complaint, and you're going to get sued because that's not going to hold up.
Right.
So you have to be able to go in and say, not only am I going to remove the teeth, but I'm going to remove about 5 millimeters of bone
Mm-hmm.
to be able to create prosthetic space to make the teeth and the gum simulation
Mm-hmm.
correct and durable.
Mm-hmm.
So you got to be able to reduce bone. Alveoplasty by the rule of thirds is what we were taught in dental school. But it has to be flat. It has to be hygienic.
Right.
Those are things that the dentist's got to be capable of doing.
Right.
I also think that you have to have some sort of sedation component, because these are pretty big cases of extractions, and most of these patients are very highly fearful. They've avoided dentists for many, many years. So you've got to be able to offer the sedation, either oral conscious sedation. We've done dozens of cases, hundreds of cases with oral conscious sedation, and it works. But now we're using IV sedation, which I'm licensed and certified to do,
Mm-hmm.
on the ASA 1 and 2 cases.
Mm-hmm.
If they're 3s and 4s, then I call in the nurse anesthetist, and they do full general anesthesia and nasal intubation and use propofol and
That's incredible.
those sorts of things.
That's incredible. It sounds like to me that, case selection is going to be extremely important for a general dentist wanting to offer this kind of service in their practice. And knowing what your limitations are, knowing when to refer to maybe a center like yours, right? To take on the real, high risk cases like an ASA 4, that's wild, or ASA 3.
I would say start out with easy cases and get some good training. I'm a big fan of the guys that, even though I've never attended it, the implant pathway guys have some good programs going on.
Mm-hmm.
I know the guys that do it, and they've got a good organization there. There's training through Nobel that you can get at Joe Marinfar's office, that he does a great job.
That's
There's
awesome.
a lot of training that you can get all over the country now for All-on-4 if you're looking for for somebody to mentor you, there's a lot of guys out there.
Which is, key.
Yeah.
Which is key.
I haven't done any mentoring for a while. I'm not opposed to it, but I'm generally so busy in my office just treating patients that I don't want to be distracted by it. So,
we appreciate you taking the time to come on here and explain and to give as much value as you have. I have a question about, the TRI system that you mentioned that you've started to get into lately. So can you, correct me if I'm wrong, but the TRI system, there are certain cases using that system which allow for not needing any alveoplasty, which may allow for, not needing to reduce bone. And so the outcome for the patient, maybe the healing might be more pleasant. The experience that the surgeon has placing the implants using that system, where they don't have to do the bone reduction, maybe that learning curve's a little bit shorter. What's your opinion on the TRI system and the All-on-X that they use, where sometimes maybe alveoplasties aren't needed?
Well, it all depends on the strength of your final restorative materials. And there's been some late developments, particularly with a software program called Blender for Dental. So Blender is a open source CAD/CAM or a computer-aided design program that allows you to segment, say for example, an STL or a digital file of an all-on-4 monolithic that you'd use in a printer or monolithic zirconia. So Blender for Dental will allow you to segment out and manufacture a bar that can then be made so that the veneering material is zirconia that goes over the top. Those are almost indestructible. So we're starting to see some ideas that we can get below that 12 millimeter threshold, maybe not reduce so much bone, put a titanium reinforcement structure in whatever prosthetic that we're hoping to make. Mm-hmm. And how that matters with the TRI is that you're recovering at least probably 2.5 to 3 millimeters of restorative space by not having to put the multi-unit abutment on top of it, which I think is pretty significant. Mm-hmm. But the proof is going to be in the pudding, where a lot of these, say for example, a 3-on-6 case, the connectors on those cases got to be really, really thick, and you have to be an absolute master at extractions to be able to take these teeth out without any destruction to the buccal plate, to the furcation of the bone. You have to be able to graft these sockets in. I mean, these are very, very difficult, advanced cases to do FP1, even FP2 type cases. Mm-hmm. In my opinion, maybe it's just the way my practice is oriented towards a certain demographic. I just don't see that many cases show up.
Okay.
Most of the people already have a lot of bone loss.
Okay.
And so the FP3 is more of an appropriate, so it's an all-on-X type case.
Right.
But I mean, I'm always looking for that magic FP1. And when it does happen, I'm going to use the TRI, because I think that's going to be that's going to be the implant that people are going to be doing in 5 years.
Well, what's your opinion on maybe using the titanium bar on, a TRI designed, Onyx tough resin from like Sprint Ray?
Yeah, I don't know the details on the physical properties of the Onyx tough. We use the Pac Dent Titan, which I think is an equivalent.
Okay.
They're probably made in the same factory and,
marketed differently.
Hong Kong, China, and put in different bottles and sold to us separately, different reps. Everybody's got to eat, but those materials are excellent for maybe up to a year. Mm-hmm. I think they're just going to continually improve. My daughter is has a master's degree in material science, and about every 2 years something even more fantastic that's unfathomable comes out. That's dentistry we're growing at such a fast breakneck pace technological wise that it's very difficult to keep up with the technology right now.
Oh yeah, I mean,
More so than I've ever seen in my career.
and that's coming from a guy who's, the first 5 people to implement it.
Yeah, but it's nuts. I think that's got a possibility, but I hope that we're not looking for solutions that solve no problem. Does that make sense?
Right.
The problem that we really have is we need a predictable material. For as much as people are paying for these cases, I don't want to put a printed plastic thing in there.
Right.
Because guess what? In a year when it's supposed to be replaced, we all know human nature with patients. They're going to forget that you told them that it lasts a year. They're going to be back in 5 years, and then they're going to be mad at you that it broke.
Right.
So I want people in a zirconia product, or there's graphananos coming out, PMMA over a bar. Those last pretty good. Material science will let us know, but prints are still for provisionals in my opinion.
Okay.
But that's the state of the art now. I'm open to ideas later on
Sure.
when new stuff comes out.
Absolutely. Thank you so
And
much.
provisionals can last up to a year. So
Right. I mean, what would it be? I mean, I might be speaking heresy here. If someone was like, just throw another provisional on there every year.
some are advocating that. But,
Really?
But what's the problem in that proposition, at least for me? I just want to talk about it.
Right.
I don't want to see you back in a year
Yeah. Yeah.
for a potential non-revenue or little revenue case.
That's fair.
When you get to scale and volume with this, your systems have to be in order to predict, to be able to put something in that doesn't need to be serviced for years. Because people are dropping 40 grand on this. You don't want them back in their office with something broke the next year.
Right.
We just ended up replacing probably a year's worth of work of prosthetics because we went on one of these rabbit holes of the different geometries of retention screws.
Oh, wow.
And, I just got so frustrated after seeing screw breakage and miss mills in the machine and, people waiting for the stuff that a lot of them, in fact, we had one today. I wasn't happy with how it turned out. He's had to come in to get things serviced a couple times. And so I told him last time, let me get new photogrammetry on this. We didn't have photogrammetry when we did this case. And I'm just going to remake it for you because I want this done correctly.
Right.
The guy was thrilled. What did it cost me to do that for him? Because
Yeah.
I got my in-house lab. It cost me $300. Now I got a patient for life, and I'm not going to have to see him except for his just annual checkups. Maybe take the appliance out every 3 or 4 years, put new screws in it. But we want to give something that's better than the teeth that they had.
This interview has been great. We're super appreciative of your time. Just to wrap it up here, at Revolution Dentistry, we're super ahead of the game with mentorship, and we think it's very important. What is your opinion on the importance of proper mentorship as a dentist learning All-on-X implants? How would you recommend a dentist seek out a mentor?
Well, get somebody that you like to work with, somebody that's got your back, somebody that you can call up when you get yourself in a situation and that would understand that not everything's going to turn out. You are going to have some failure.
Mm-hmm.
I think it's overhyped how well All-on-4 works. Somebody commented on Dental Town, or I don't know where it was, probably Dental Nachos or something the other day, that, going to a specialist, you get 98% of your implants work. Going to a GP, you only get 85% of your implants work. Well, that's not true. Not true at all. Because tell me how many patients go back to the specialist that placed the implant when the implant fails.
You tell me.
None. They're at the dental office.
Right.
Letting him deal with it. So you see how that kind of skews those results?
Oh, okay. I get what you're saying. Absolutely.
Yeah. even if that's just a 20-30% percentage of it, that throws those numbers off.
Right.
So I think the mentor should be somebody that is a good general dentist that's very experienced in implants, that has the chops surgically and restoratively.
Mm-hmm.
Not all specialists are restorative dentists. Not all specialists understand occlusion or how to change occlusion if a patient comes in with a pathologic joint. They just let that kind of sweep under the rug, and then they start pointing fingers at why the case didn't turn out.
Right.
So get somebody that's a restorative trained dentist that's proficient in implants. And if you talk to those nurse anesthetists who go to everybody's office, that's what they'll tell you, is the guys I'd have doing my all-on-4 are the advanced GPs.
Wow.
So that's the kind of mentor that you want to look for.
That's powerful. That's very powerful.
I'll take some heat for that, but I mean,
hey, you won't take as much heat for it nowadays as you might have in the past.
True.
But, I want to know, are there any exciting projects you got coming up that you want to share with people? I know that sometimes you appear on webinars, stuff like that. Anything that you would like to mention?
I think we're going to go a little bit deeper dive on the TRI implant.
Okay.
I know one of my complaints with it initially was that the threads aren't aggressive enough. Mm-hmm. Remember when you guys asked me about how the what kind of implant system you're looking for?
Right.
So these little guys, I got one out. I don't know if you can see it. Probably can't focus.
Let me see.
But these threads are just, for lack of better terms, they're real weenie. They're just not very good threads. So they're re-engineering these to more of an American immediate load type taste.
Okay.
Once they've got that, I think this is the implant to use.
There you go. You heard it here, folks.
I'm using them. I use them for all my single unit and 3-unit bridge cases already.
Okay.
Because the retention screw is much better. There's going to be some changes in the engineering and the screws coming up. That's what the next project's going to be. I think I'm working a little bit with Brady, with Brady Frank. He wants to start some mentorship of some sorts.
Okay. Awesome.
I haven't committed yet, but I'm very intrigued by his possibilities that he's got.
Awesome. Well, if you end up going down that path, we'd love to hear from you and see if we couldn't get some of our listeners connected with you for some mentorship and training.
Yeah, I think probably being able to give all the information that I've accumulated on what works, what doesn't. I had a guy call me the other day that wants to set up an in-house lab. Mm-hmm. And boy, I could be a lab setup consultant at this point.
I bet.
I know how to wire 240 volt circuits for the compressors.
What?
I know how to, I've done all I got a construction management degree in undergraduate. I know how to plumb. I know how to wire. I know how to set these things up, and I know how to make them redundant systems so that they work. Because when you get to a volume, you got to have stuff work.
Of course.
We've got 5 different CAD/CAM machines now, all different manufacturers, because I don't want to buy one from the same manufacturer. If they do a software release and it junks all of your machines, we're dead in the water.
Dead in the water. Can't have that.
We can adapt and throw stuff. We do it all day long at different, throw smoke at different stuff. So anyway,
Absolutely.
that'll give you some ideas.
No, of course. Thank you. If someone wanted to reach out with maybe a question or some kind of, situation, we are going to put Dr. Chris Winterholler's information into the show notes or description of this episode. If you guys are interested in reaching out with a question concerning some of the topics we've touched on today, feel free there. So without further ado, I would really love to just thank Dr. Chris Winterholler for joining us today on the Revolution Dentistry podcast. We've learned so much about, the All-on-X process and his story and his recommendations for dentists trying to implement this into their practice. So without further ado, thank you so much, everybody, for tuning into the Revolution Dentistry podcast. If you're finding value here, please make sure to hit subscribe so you never miss an episode. We're here every week to help you grow. Thank you so much. Bye-bye.